She is a partner in the law offices of Jones, Mays, Ramsey and Parekh and is licensed to practice law both in Texas and California. Her area of practice includes estate planning, probate, real estate and corporate law. She is a legal counsel for various Indian non-profit organizations. Mona has really been a driving force between a lot of new innovations in the chamber this year. Ladies and gentlemen, it's my privilege to welcome Mona Parekh, the president of the Indo American Chamber of Commerce. And she will be followed by Dr. Thank you.
Thank you for those kind words, deeply appreciated. Well, ladies and gentlemen, it has been a year since the Patient Protection and the Affordable Care Act was passed. The idea was to overhaul the national health care system and to make insurance accessible and affordable to tens of millions of Americans. Ever since the bill was passed, immediately several states have filed challenges to invalidate it. Currently, as it stands, 3 federal courts have upheld it. 1 federal court has invalidated the individual mandate which compels individuals to either purchase insurance or to pay a fine. On the other hand, another federal court has clearly declared the entire act void. As it stands, this bill is certainly headed to the United States Supreme Court for resolution. In the midst of all of this, some provisions of the act have certainly taken effect. Others, the President and his team actually are now possibly suggesting that an amendment to the bill may be forthcoming, that states may have the option to opt out of it. In the midst of all of this confusion, I'm sure all of you have seen the current papers which talk about the budget battle which is ensuing. You know, the debate in Washington has certainly reshaped. It has shifted from, I'm sorry, can you guys hear me well?
Yeah.
Okay, good. Maybe it's just my voice. There you go. The debate has certainly taken a new form. You know, currently, what used to be where people were talking about how much more can we spend to emphasize on stimulus programs. Today, everybody acknowledges that the idea is to go ahead and cut some of it. Given all of that, it still doesn't matter as far as the US population is concerned. We've got an aging population and a growing population. So the need for healthcare is just as important as it ever was, and the demand is outgrowing. In the midst of these conflicts and challenges, each and everyone here is aware of many of the innovations that are taking place in the healthcare industry. We look around, physicians, pharmacists, researchers, every individual involved in the healthcare sector is trying to provide a more efficient and an effective way of healthcare at a reasonable cost. Cities, in fact, are now involved in actively seeking federal grants to foster a more healthy lifestyle. These include expanding our bikeways and our walkways. Researchers are taking the step of using electronic medical records to help with faster searches as far as enrollment of patients are concerned, with the potential that today what happens to cost almost $1 billion for any new drug or any major treatment to hit the market may possibly be reduced, and it may also result in a quicker delivery system. Pharmacists, gosh, they are innovative, I tell you, in terms of just expanding their practice to increase more personnel within their office to just follow up on patients to see if they are taking their medication, to investing in non-traditional dispensers which can help track the actual usage of medication is unbelievable. Houston remains the home to the world-renowned Texas Medical Center. In the midst of all of this commotion, the healthcare industry is probably the only sector that gained jobs throughout the recession. Ladies and gentlemen, I believe that the opportunity for investment and business is ever expanding. Given those dynamics, On behalf of the Indo-American Chamber of Commerce, to all the physicians, pharmacists, researchers, hospital administrators, practice managers, we want you to know that this chamber clearly recognizes today's dynamic and complex healthcare environment. While strengthening the evolving relationship between the United States and India is our priority, we are also equally committed to the continuing success of each of our members, including all of you who are economically vested in the progress of the healthcare arena. So on behalf of the Indo-American Chamber of Commerce, it is my distinct honor and privilege to present to you this year's very first program on the healthcare initiative. And I welcome you to participate and hopefully have a dialogue with our advisor. At this moment, I would like to kindly request my fellow board member, a well-recognized individual, a well-admired physician, Dr. Subodh Gujjar, to please introduce our keynote speaker. Ladies and gentlemen, Dr. Subodh.
You got a new mic out here. Good evening, everybody. It's indeed an honor and a privilege to introduce our featured speaker today, a friend of ours, a friend of mine, someone I've known for many years now. I first met him, Mr. Wolterman, in about 1999 or 2000 when I served on the board of Memorial Hermann Hospital System. And when I saw him in the meetings, I had this hunch and a good feeling that one day he's going to lead the Memorial Hermann System. And in 2002, he was named the chairman and the president and the CEO of Memorial Hermann Hospital. Now, lawyers can, of course, they don't need these papers, but doctors do need documentation. So I'm going to read some of his achievements. Mr. Wolterman, as I said, joined Memorial Hermann in 1999 and was named the president and CEO in 2002. Before joining Memorial Hermann, he was a senior vice president of the Sisters of Charity of the Incarnate World Healthcare System. Mr. Wolterman earned his BS degree in Business Administration and MBA in Finance from the University of Cincinnati and a master's degree in Healthcare Administration from Xavier University. He has served as chairman of numerous organizations including the Greater Houston Partnership, Texas Hospital Association Board of Directors, and VHA of America, Texas Board of Directors. He presently serves as chairman of the AHA, that's the American Heart Association Houston Region, and 2011 National Seniors Games. In addition, he serves on the Joint Commission Center for Transforming Healthcare Leadership Advisory Council. He continues to serve on the Greater Houston Partnership Board of Directors and VHA, as I mentioned. In addition to his role as president and CEO of Memorial Hermann, and serving on numerous city, state, and national committees, he's also an adjunct professor at the University of Texas School of Public Health and serves on the University of Houston Clear Lake Healthcare Administration Program Advisory Council.
Thank you, Doctor, for that. Sorry, allergies in Houston. Any doctors in the room? We appreciate those kind comments and your friendship all these years. Before I get into the presentation tonight, let me just say it's an honor to be here, and it's been a real privilege to be the advisor to the Indo-American Chamber of Commerce here in Greater Houston for many years. I jag deep in the whole organization. As a class organization, I got to know it a lot better when I chaired the Greater Houston Partnership. We established some deep relationships then, and it's really been, like I said, a privilege to be an advisor on the healthcare sphere for your organization. You're in good hands, and that's why I'm here tonight as a payback to working with this group. I would also be remiss if I didn't say my own personal congratulations to Dr. Reddy, the first Indo-American to be the president Medical Society. I try to give you promotion to the hospital side. You don't want that. The Medical Society. That's quite an achievement, and I can attest Dr. Reddy is one to recognize you. Now let's get into the conversation. Healthcare. What a dynamic topic. Anywhere you read, you pick up newspapers, you turn on the TV. If you're one of those people that listens to those talking heads on the radio, healthcare's occupying all the headlines. And a lot of it's around this health reform bill that was passed a little over a year ago. So we passed the 1-year anniversary. My intentions tonight is to really give you some fundamental understandings of that bill and then talk about where I think it's going. But before I do that, I think we need to be grounded in the same basis of why this bill is here. And let me start with that basis. First and foremost, do not get caught up in this health reform bill. It is not about the bill. What I will tell you, whether this bill is there or not, the American healthcare system, as we have known it for many, many years, is fundamentally broken and needs transformational change. By any measure, you cannot say our system works well. We have 50+ million Americans without access to health care, no health insurance. We have a cost in this country of health care astronomically high, and I'll get to that in a second. And the health of our people. It doesn't matter what city, what state, if you compare it to the rest of the world, it's not very good. And so the idea that we want to preserve what we got and it's sustainable into the future is a flawed notion. The system is not sustainable. It must be changed. Now, I will tell you later tonight that the way this bill is not the way to change it. And I believe there's other fundamental, better ways to do it. But to say, let's just leave it alone, let's ignore it, and let's just keep going, it's a train wreck. And let me tell you why. It's a cost issue. Right now, let's talk about the numbers. If you go back just 1 year, and I use 1 year because it's an easy math, the United States healthcare bill, the total expenditure was $2.5 trillion. This current, last year just ended, it's up to 2.8, by the way. But let's use 2.5 trillion. At $2.5 trillion, on a per capita basis, the United States spends double any other country in the world. Double. Now, you can say, well, that's okay if there's a value for that spend. Well, how do you define value for a dollar spent in healthcare? You define it by saying, is your population healthy? Because if you're going to spend a dollar for healthcare, the people ought to be healthier. And when you look at all the world studies, and there's a number of them out there, the United States, the last studies out, rank anywhere from 38th healthiest to 54th healthiest. So we spend double anybody else per person, and we're roughly 40th healthiest population in the world. There's no value in that. It tells you we're spending our dollars in all the wrong places. I'm a proponent that says $2.5 trillion is plenty of dollars to get a return in the healthcare industry. But what all this is about is that the cost curve of healthcare is rising so dramatically that in 2017, using the government's numbers, healthcare in this country will cost about $4.4 trillion. And it's going to eat up more than 20% of the gross domestic product of this country. Can't do that. No other country in the world does that. Particularly if our population isn't healthier, more productive, and able to be in your places of business and working in a productive fashion. So, with that premise that cost is out of control, where do we go? How do we get to a system that's good? And I know when I get in groups like this, people always challenge me and say, well, Dan, I understand the cost. I But isn't the American healthcare system the very best in the world? And that depends on your perspective. But here's my response to that. The American healthcare system is by far the best in what I call rescue care. If you have a heart attack, you have a stroke, you're in an automobile accident going home from this event tonight, God forbid, there's no better place in the world, and frankly, there's no better place in the world than right here in Houston, Texas, to be. We can rescue you. The physicians in this room, the outstanding hospitals we have in this city and throughout the country, we will rescue you. And we'll bring you back to a pretty good quality of life, particularly if we can get you in that first hour after your event. Or if you get cancer, survival rates are high. That's all rescue care. But what we need to be about is health care. And when you look at even our own communities, look at our health indicators. Look at how many teens are pregnant. Look at how many mothers are delivering babies without any prenatal care. And they end up going into the neonatal intensive care, costing society a lot of money. Look at our obesity rates. Look at our diabetic rates. And I could go on and on and on. That's where it's broke. We are not serving the patients well. So we can try to hold on to this system, but it's doomed to fail. The costs are going to strip it down, and the employers in this country will not be able to afford health insurance. Frankly, right now we got a Band-Aid on the system. Those of you in the room that are offering health insurance to your employees, in order to keep it affordable, you changed your plans a lot over the years. We've done it ourselves. Memorial Hermann's the largest private employer in the greater Houston area, 22,000 employees. How do we change it? We simply hold the premium down by passing more of the costs on to our employees. We do that through more co-pays and deductibles. It's not unusual for a patient to have to pay the first $2,000 to $5,000 of health care bills before insurance kicks in. And so they avoid care because they don't have that money. That's not a health insurance system. We claim they're health insured, but we don't talk about who's adequately insured. There's a lot of people that have insurance that are underinsured besides the uninsured. And we ignore that. And that's a problem. So when Congress came together a year or so ago, there was a debate about health care. Congress sees these same numbers. We have the Senator Cornyn's representative, Jay, is here. He knows these numbers. They're wonderful. The Senator's office is a great resource. They understand these issues. Jay's been wonderful to work with. But there are certain numbers you have to understand. And then I'll go into the health reform bill. When you look at the federal government, a year ago, they're looking at big deficits, coming off of tough economic times. We still have big deficits. $1.5 trillion. And when you look at what's contributing to that, you've got to see front and center Medicare or Medicaid. And the numbers, these are round cuts of Medicare or Medicaid, they're going to be significant cuts. And yes, the recipients of Medicare probably have to bear a little bit more of that too. But does that mean that all we do is cut what we pay doctors or cut what we pay hospitals? That's a faulty view. That's what we've been doing for the last 20 years, and it's done nothing to change the cost curve. Because what happens is our system is based on what? We get paid on what is called fee for service. You only get paid if you do a service to a patient. And the sicker the patient is, and the more intense the service, the more you get paid. The incentives are perverse. You get nothing in pay to keep somebody healthy and well. And you get paid a lot more to put a cardiac stent in them than to try to keep their cardiac condition under control. And when you cut a hospital or physician's pay, all we do is make it up by doing more. More volume, more volume, more volume. And if you look at what's causing the cost to go up in this country, it's not price. And this is what it's hard to talk to congressmen and any other legislators, is that cost is not what you pay a doctor or a hospital. That's price. Cost is defined as price times volume equals cost. And we have to get volume under control. And as long as you pay the system a fee for service, it's not going to come under control. Now that's controversial in my industry because everything we do is based on a fee for service. The Memorial Hermann system has 128 service sites in Greater Houston. Every one of those sites, whether it be imaging centers, surgery centers, hospitals, rehab centers, is a profit center. And that model is based on get more volume, drive my price up, and that's how we make money. And that's how we cover the cost of the uninsured. But that's a bad economic model for this country. We will never get improved health if we stay with that model. So, that's kind of a backdrop to move now into the health reform bill. So remember, let me state up front, this is nonpartisan. I'm not going to take shots at either side. This is not about that. It's about facts. There are some good things in the bill. There's a lot of things in the health reform bill that need to be scrapped or significantly modified. I'll put that right up front. It is a very flawed bill. But one of the things you got to understand is the bill does nothing about the cost side of health care. Contrary to what you may read, it's not a bill about reducing the cost or the cost curve. It's a bill about access to care, about access to insurance. It's really an insurance bill. And it's a lot of money and a lot of complications. But the way they pay doctors and hospitals do not change under this bill. Doesn't change at all. They put a lot more regulations and hoops to jump through, but it's not a change. And so people like me who study the system now for 30 plus years and speak all over the country, this bill is not going to get us where we want to get to. It's got laudable goals to ensure and get access to more Americans. But if that was your goal, then you wouldn't leave 18 to 20 million Americans still without insurance in 2019. Because the bill was only going to cover about 32 million Americans, not the 50 plus Americans. And so it does not get you everywhere. And so where do we go? If you're not familiar with the bill, again, it was passed March a year ago. It's over 2,000 pages. I'm sure Jay's seen it. If you stack it up on the floor, it stacks up about this high. I have it still in my office as a memento. I've read it many times. It's a very poorly written document from an English and another perspective, but that's how some bills are. When you go through it, what you see is over 1,000 times it says, in key parts, the Secretary of Health and Human Services shall. All that simply means is code for regulations have to be written by the administration. When you got that more than 1,000 times, you got some difficulties. And I try to tell my colleagues that every time there's a regulation to be written, for every 1 page of the bill, there's anywhere from 10 to 100 pages of regulation. A classic example of that happened last Thursday when a key part of this that the provider community was looking forward to, which is called accountable care organizations, which is doctors and hospitals coming together and being accountable for managing the health of people. And if they do that well and lower costs and improve quality, they get to share some of the upside of that. Great goal. We've been waiting for those regs to come out. They've been delayed. They came out last Thursday. It's about 3 paragraphs in the bill on ACOs. That's what it talks about. Only about 3 paragraphs. But to implement those 3 paragraphs is 429 pages of regulations. 429. And now we're all trying to decipher it. And so we still got a lot of regulations. So can anybody tell you where this bill's going? No. There's a lot of regulations still to be written. There's a lot in Congress that feel it shouldn't be funded. Actually, the House, and the Republican side of the House has passed numerous bills in the last few weeks defunding certain aspects of it. Now, those bills aren't going anywhere because the Senate is highly unlikely to approve them and pass them. And if they did, it's highly unlikely the president would sign it into law. So they are recognizing some issues. But the law is flawed, and let's talk about some of the fundamental underpinnings. When they started, they made a promise, the administration and the Democratic Party, that over a 10-year period, this bill would not cost the country more than $1 trillion over 10 years. Did they hold that? According to CBO at the time, yes, they did. They came in the low $900 billion. Today, the CBO has adjusted it numerous times, and it's now well over $1 billion. It's approaching 1.4, 1.5 billion. So they were wrong. We all knew they were wrong when they did that. It's not going to save the country money because over what they were projecting. It's actually going to cost more. Anybody that can tell you that we're going to allow 32 million more people into the system that haven't been able to do it, and costs are going to go down, that's foolhardy logic. It's going to go up. Look at the state of Massachusetts, and you will see what happens when everybody gets in. They got about 98% of their population covered now. Their costs are going to the ceiling. Not enough doctors to take care of them, and on and on. So, how are they going to pay for that $1 trillion? Well, the revenues to pay for this come in two different sources, and I'll just lump them. One is they're going to increase taxes and penalties and other things on mostly employers and individuals. So that's one source of funding. It's about 50% of the funding. The other 50% comes from reducing payments to doctors, hospitals, and other providers and vendors who serve the healthcare industry. So 50% come out of us who are serving the people. The other 50 come out of some form of taxes, penalties, and various other sundry ways. Now, where does that money go? If you're not familiar, most of that money is used to subsidize health insurance premiums for lower income individuals. People who may not have insurance today, that will be their incentive to go purchase that insurance. And so the concept was we're going to use that money, subsidize these individuals, and they will go out with those subsidies and be able to get health insurance and therefore access to care. I think that's right on, but the problem is the subsidies are pretty rich. If you haven't looked at it, the subsidies go all the way up to somebody, a family of four, of 400% of federal poverty level. What does that equate to? That's about anybody making $88,000 will get some form of subsidy or less. $88,000 in my mind is not poor. It's not rich, but it's doing okay. But they will, under this bill, have some form of subsidy. The lower your income, the more subsidy, including 100% coverage. Now, the lower income people will be subsidized into Medicaid systems in each state. They're requiring in this bill that every state cover up to 133% of poverty level for Medicaid. Now, compare that to Texas today. We only cover 100% of federal poverty level. So Texas has got a big bill coming due if this bill goes through. And you already hear about the current budget problems with Texas and Medicaid. And the House bill that just approved this week is $6 billion short of funding fully the Medicaid caseload predicted for the next 2 years. So the bill they passed in the House on the budget is $6 billion short of funding the case load that they are projecting for Medicaid in this state over the next 2 years. And we're not even talking when this bill kicks in 2014. So you have those issues there. A lot of people get subsidies. But let's talk about a couple other things I think are important, and I'll open it up. One, there's faulty math in how this bill was sold to the American public. And we need to acknowledge that. Is it true that the deficit is not added to over these 10 years because of this bill? If you believe CBO, the answer is yes. Let's just assume they're correct. But it's misleading. It's not telling you the full story. It hasn't told the American public the full story. How did they do that? How they did it was all the revenue side, the taxes and the provider cuts, they kicked in 2010. So they're counting 10 full years of revenues. But the expense side, the benefits to people who get coverage, doesn't kick in until 2014. Now let's put that in your personal home. If I told you you get 10 years of salary, but you only have to pay 6 years of your home expenses, could you balance your budget? I think so. That's funny numbers. The real numbers are what happens in a year that revenues and expenses are the same. That's year 11. And I know Jay knows, if you go to the CBO study, you'll see that number, and it's negative. It's hundreds of millions, of billions of dollars negative per year, and it just keeps going. It doesn't work. You can't say it balances by taking 10 years of revenue and 6 years of expense. So we'll put that one aside. The math doesn't work. Now, what are some of the more troubling aspects of this bill that you need to be aware of? In my opinion, and this is my interpretation, a lot of regs to be written, here's my biggest concern. The concept is America needs to do this to get more people insured. And that by doing this, we are incented through mandates to have insurance. There's logic to that. That people who are uninsured raise the cost of people who are insured. And let me give you the facts. If you look at a hospital, I know my system, those that are insured are covering the underpayments by the federal government for Medicare. Because on my business, we get about 84 cents of every dollar of costs covered by Medicare. On Medicaid, we get about 58 cents of every dollar of cost. On the uninsured, it's 8 cents. Because there are some people who choose to be uninsured, and they have resources, and they do pay their bills. So it's about 8 cents. That's 60% of my book of business. Pays less than their fair share of costs. 60%. So that leaves the remaining 40, you all that are insured, or you all as employers who are providing insurance to cover that. Why is your insurance cost so high? Because I'm shifting that to you. And I've been doing it for 25 years. It's the only way to survive. What does that cost? For our system, it's $1.48 for every dollar of cost that we get from the insured patient. $1.48. Now let me put it in perspective. My system needs between 2 and 5% operating margin as a nonprofit to continue to keep our technology up, replace our equipment, etc. So only 2 to 5% margin. So if everybody else was paying 100% of their costs, theoretically you could take that $1.48 and drop it to $1.05, give me a 5% margin, and we all would be fine. So there's a 45% reduction right there if everybody's in the game. And that was the intent. So it was a laudable intent. But everybody will not be in the game. And here's why. When you look at the bill, it runs this way. First requirement is of you as an employer. You have to provide health insurance to your employees. If you choose not to, which is your right, then you will have to pay a penalty. What is that penalty in the bill? It's $2,000 a year, $2,000 per employee per year penalty. And that's the rough side. It varies, but that's what it roughly is. $2,000 per person per year. Let's put that in perspective. What's the average insurance premium employers paying in the United States today? It's about $8,000, $8,500. For a family of four, it's about $14,000. So, let's take Memorial Hermann. We're self-funded for all our employees and their dependents. I know last year we spent $102 million on doctors, hospitalizations, and other services. $102 million. At 22,000 employees, times, if I opted out, times 2,000, the number is pretty simple. It's 44 million. So if I opted out, Memorial Hermann would save $60+ million a year by opting out. If my fees get cut and everything goes, I'm going to need that 60. Just as you and your business, when you look at it, are going to need that money. And those are bigger companies who have shareholders are going to demand the hundreds of millions of dollars of savings. By setting the price so low compared to what current healthcare costs are, you're incenting, in my opinion, employers to drop health insurance, not add health insurance. And I can tell you, I speak all over the country. The last seminar to all major employers, there's 37 of the top 50 employers in America were at it. When I got done, I asked from the podium, how many in this room are considering dropping their insurance in 2014 when this bill takes effect? Every hand went up. And when you ask them why, it's for the same reasons. It's a cost savings we have to fundamentally look at, or our shareholders will demand we look at it. So let's play that out. Let's assume that employers drop. Memorial Hermann drops its coverage for its employees. Then what happens? The individual mandate kicks in. That's assuming the Supreme Court says it's constitutional. But let's just play it out like the bill's written. Then the individual mandate kicks in. So, you're a Memorial Hermann employee. I no longer provide you health insurance. You have to go buy health insurance. So part of this bill says each state has to set up a health insurance exchange. And that in that exchange there will be a whole variety of health insurance products you can choose from. And they're really just like your credit cards. You can get a bronze plan, a silver plan, a gold plan, and a platinum plan. And what varies is price and benefits. But you choose. That's the theory. Each state has to do it. Well, Texas is behind the 8 ball on that because it looks like the bill in the legislature isn't going to pass, so we're going to be a federal health insurance exchange unless things change. But put that aside, the individual has to go out and buy. So they're going to go to this health insurance exchange. And what is the cost going to be? Most experts will say in 2014, when this kicks in, the lowest price premium, the bronze plans, will probably cost somewhere in the neighborhood of $6,000. The decent benefit plans are going to be in the $7,000, $8,000, $9,000 range. So if you're an individual and you're making $30,000, $40,000, $50,000 a year before taxes, and now you're faced with going out and buying health insurance at $6,000 to $8,000, would you do it? Well, the question comes down to what's my individual mandate? What's my penalty if I don't do it? In 2014, anybody want to guess? If you got to pay $6,000 to $8,000, what's the individual mandate? What do you got to pay as a penalty if you decide not to buy health insurance? It's $98. Now think about that. Who would buy? Now the whole concept here is let's get the young and healthy people into the system. Because right now they're uninsured. They're gambling that they're young and healthy and they're going to stay that way. And most of them will. We want them all in the system. And now you're telling them get in the system, but oh, you can get out for $98. And I'm sitting there going, $6,000 or $98? Wow, tough decision. Okay, so the employers drop it, the individuals opt out by paying the penalty, $98. It graduates up, and depending on your income, it's a little higher than that, but I use that as an example. But if that happens, the uninsured rate in America does what? It skyrockets. Skyrockets. And so I think that's the fundamental flaw in the bill. Now, people say, well, that won't happen, Dan, because you as an employer won't do that to your employees. That's not necessarily true. If you look at Memorial Hermann, there's a lot of my employees that are on a lower income level. We pay them well above minimum wage, well above a sustainable, livable wage, but they still are going to make enough to fully qualify for 100% subsidy under this bill. So right now, I require them to have health insurance, and they have to pay their fair share of the premium. It's roughly $50 a paycheck for them. That's a lot of money for these people. And now they're going to come to me and say, why are you making me do that, Dan, and pay that $50 per pay period when the government says if I go over here, I get 100% coverage and subsidy? So as an employer, I wouldn't force that. I would say go ahead and opt out. Go ahead over here and get that subsidy. But if I stayed in the plan and the employees opted out, every employee that opted out is no longer $2,000, that penalty goes up to $3,000. Okay? So if you do health insurance and people opt out, you got to pay $3,000. And I will contend, unless everybody's a professional making over $88,000, the ones that get subsidies are going to opt out. And so there's this whole concept here that you're hurting the employees. You're not. Because the other employees that make $88,000 and above that don't get subsidies, I'll simply, as an employer, say, to make it worth your while, I'll give you an extra $2,000 a year in pay. You can use that to go buy health insurance on the market, or you can do whatever you want with it. This employee's going to be pretty happy. So I don't believe there's an incentive for anybody to buy. And then the individual, why would you buy insurance? There's only one reason you buy health insurance, because you think you may get a catastrophic illness. You don't want to take that risk of losing all your assets if you get sick. And you end up in an ICU for a long period of time. But what's this bill say? And this is the last thing I'll talk about. The bill says this, that at no time can an insurer deny any individual health insurance coverage for a pre-existing condition. Makes sense. But let's play that out. It's 2014. I walk out here tonight, my phone rings on the way to the parking garage. It's the police. My wife's in a terrible accident. She's got polytrauma. She's in a coma. She's going to be on a ventilator for a while. When she recovers, she's going to be in TIER, very expensive facility. It's going to be hundreds of thousands of dollars. And oh, by the way, I paid the $98 to opt her out of health insurance. What do? Here's what I do. After I check on her when I get to the emergency room, waiting room, and the doctors are working on her and ask me to leave for a while, I pick up the phone, I call the state health insurance exchange. I say, what's your very best coverage plan? Your platinum plan. How much does it cost? $20,000? Okay, here's my Platinum American Express card. Her name is Lori Wolterman. Sign her up. They cannot deny. So you could go without coverage. The moment you have a heart attack, a stroke, or an accident, your loved one could call on your behalf, sign you up, and they cannot deny that pre-existing condition. To equate it to something you know about, it's like you going home tonight and your spouse calls you and says your home's on fire and you forgot to do the homeowner's insurance. You call State Farm and say, I want to buy a policy, it's $2 million, here's my investor out, the house is on fire. You cannot have insurance if you don't know what you're insuring. If people can come in the system anytime they get ill and only pay their premium, it doesn't work. And people say it won't happen. And what happens in the state of Massachusetts, again, if you look at that state, they've had a 2.5-year, 5.5 months. 5.5 months. And when you talk to the insurance companies, what they tell you is they only buy it when they get an illness, and they drop it after the last bill is paid. That's a tough system. So we got to change those. If you want a health access bill, you cannot allow people to opt in and out at a whim. You're probably going to have to say you get one option a year. If you opt out, you're out. Okay? That bill doesn't say that. You're probably going to have to raise the penalties to a much higher level to encourage people to stay in. That's politically tough. It's already a controversial health reform bill that really reforms the delivery system, that takes out the episodic, fragmented care that we do and encourages and pays doctors and hospitals and other caregivers to work in a team concept to keep people healthy and well, and when they're ill, to treat them in the most efficient, highest quality manner.
The one I'm going to ask you is...
Maybe one per person.
One question. You talked about providing an efficient, quality system, healthcare system, providing that as an alternative to reform the delivery system. How much of the dollars that you pay out to your personnel, that's including doctors, everyone else, is part of your actual expenditure right now?
Well, in Memorial Hermann's case, we employ very few doctors. We only have about 70 that are employed. For all our workforce, our payroll is about $1.2 billion out of a total expenditure of our system of about $4.5 billion. So we're a very efficiently run system. So the payroll is our biggest single expense, but it's a lot lower than a lot of hospitals in the country, which run about 50% of their expenses being payroll.
As County Medical Society, the largest medical society, county medical society in the nation, with a membership of almost 11,000 physicians and medical students. The society's activities impact us all, since part of their mission includes promoting the highest standards of ethical medical practice, access to quality medical care, medical education, research and community health, much of which you heard about today. Guru is the first person of Indian origin, as you heard, to serve in this important role. Guru is a board-certified gastroenterologist and hepatologist in private practice and a clinical associate assistant professor at Baylor, where he received his training. Over the years, Guru has served his patients, our hospitals, and our community in many ways. To name just a few, he serves on the board of the Gulf Coast Regional Blood Center. He serves on the board of the Museum of Natural Health and Medical Science, the advisory board of the American Liver Foundation, board of Texas Gulf Coast Gastroenterology, and others. And he served professionally in multiple roles, including in the hospitals where he served as a chief of staff, trustee, and chair or member of multiple committees. And his many achievements in gastroenterology and medicine have been recognized broadly. To name a few, he's been named Newsweek's Best Doctors of Texas, Houston's magazine's Top Doctors, as well as Consumer Guide to America's Top Physicians.
Thank you, Guru. Could we have a few words, please?
Jagdeep and Mona Parikh, the president, past presidents, distinguished members of this organization, fellow physicians, I'm truly humbled this evening to be recognized amongst my peers, colleagues, and so many friends. It's almost like homecoming for me to see so many of you, like some of you that I've not seen for a long time. Dan has done a wonderful job this evening, so beautifully dissecting the healthcare reform, a complex compendium as is illustrated, which is more than 2,000 pages. He's certainly courageous, he's innovative, he thinks outside the box, and he believes in disruptive innovation. We all know that in today's healthcare, the only thing that truly can work for the future is those who can think in terms of disruptive innovation. And those of you who are MBAs and business majors, you understand the new terminology of disruptive innovation. And I'm very hopeful that a man like Dan Wolterman, will contribute tremendously in understanding this reform and doing the right things for the medical fraternity. If I had a chance and opportunity, I would certainly recommend to President Obama, if he has to write the course of the healthcare reform, he should appoint Dan Wolterman as the new czar of healthcare. And lastly, I just want to comment, I want to recognize Mr. Greg Bernica, who is our CEO and Executive Vice President of the Medical Society. Greg, there he is. I think Greg has been leading the society for more than 20 years, a brilliant administrator who runs a team of more than 30 people. And with regards to the medical society, truly this is the largest county medical society in the country today, having over 11,000 members plus residents and students. This society is particularly proud in the country and the state of Texas for many reasons, and just to name a couple of them, for the landmark tort reform, the medical liability reform that we achieved in the year 2003. At a time when doctors were leaving Texas by droves, particularly neurosurgeons, obstetricians, gynecologists, and many other physicians, the trend has reversed now because of that landmark tort reform that this society and the physicians who have contributed to its success have been emulated across the country by many other states. And now there are more than 10,000 physicians who have returned back to Texas, and Texas today seems to be the #1 state in terms of a preferred job opportunity and a place to practice medicine. So without much ado this evening, we're all here to do our best. And one important thing for doctors at any time, irrespective of what happens with healthcare and how this is going to translate and pan out at the end of the day, we believe in that ideology and the premise of what we call as patient-physician relationship. This is the greatest asset that we have in this country when it comes to taking care of people who are sick. It's not the great institutions, it's not the infrastructure, it's not the technology. Why we are the best at the end of the day, it is that great understanding of our patients and trying to preserve the patient-doctor relationship. So no matter what may come, what system may evolve, what stakeholders may influence at the end of the day, I think as physicians, we are going to strive to preserve that relationship, to serve our patients to our best of our capabilities and keep them healthy. Thank you very much, and thank the IACCGH.